My name is Deborah Duquette, and I'm from the Michigan Department of Community Health, and I'm the genomics coordinator there.
And I'm Bev Burke with the Connecticut Department of Public Health, and I'm the coordinator of our genomics office.
Hi, I'm Janice Bach, and I'm with the Michigan Department of Community Health. I'm the state genetics coordinator, but I also administer the genomics and genetic disorders section, which is where our genomics program is housed.
Hi, I'm Summer Cox, and I'm from the Oregon Public Health Division. I'm the coordinator of the Oregon Genetics Program.
We have all heard a great deal about genetics and genomics and the promise that is supposed to come to us, and I think we've seen a fair bit of promise in the research area. I don't think we've seen as much in the applied health, in the public health area or arena, and you all have been really pioneers in that area and been able to do some extraordinary things, I think. So if each of you could talk about what your state has done, what you've done, and how you've been a pioneer in this area, we'd very much like to hear about it.
I have been working in state public health since 2004 and worked in pretty much every chronic disease realm that you can think of about integrate genomics into state public health programming. But the ones that we've been working on most since 2008 have to do with the Tier 1 applications related to BRCA, hereditary breast and ovarian cancer, and Lynch syndrome as well. And we're also starting to get into familial hypercholesterolemia.
Tier 1, and maybe it'd be good to go to Janice because she's in the same state you are. Can you say something about what Tier 1 means?
Well, Tier 1 is a definition that's coined by CDC that refers to genomic applications that really are ready to be implemented on a wider public health population-based scale. Examples that we're talking about today have to do with situations where there actually is a specific test that has been found to be evidence-based to really reduce morbidity and mortality.
It's the evidence-based testing that's really crucial. We have so much genetic information out there, but to parse through that and to find the things that are ready right now, that have the evidence that says these will save lives if we can get them out into our community is really where the passion is.
And are you doing this in Oregon?
We are, absolutely. One of our biggest overall goals is to help people, clinicians and insurance companies, promote and use evidence-based testing following USPSTF and NCCN guidelines. And following those guidelines can really help clinicians make the right choices for which tests to offer, and can also help insurance companies be very consistent in providing appropriate care for their clients and covering it.
I think the importance of the Tier 1 applications being evidence-based are important in our public health messages, because it certainly helps when we're promoting the recommendations both to clinicians and also to the public. I think it adds credibility to our public health messages about prevention efforts. It adds a validity for the recipient of the messages, but that these have scientific base or evidence-based.
And I think it's extremely important, especially for BRCA, to have that 2005 USPSTF recommendation for those women that have a significant family history of breast or ovarian cancer, that they should be referred for genetic risk assessment for consideration of BRCA testing. And then there was also at the same time that came out what we call a grade D recommendation, which actually said that there was an inappropriate use of that test and that it should not be offered to individuals in the general population that do not have a significant personal or family history. Embody what genomics and public health is all about, trying to promote those things that are most appropriate, as well as trying to make sure that inappropriate testing isn't occurring as well. Unbeknownst to us, with the Affordable Care Act, it also became even more important because our grade B USPSTF recommendation is something that should be covered by the Affordable Care Act.
Tier 1 tests, as I understand it from you, have risen to a certain point where they're acceptable, and they sound like they're most acceptable for two reasons. One, there's evidence that they would have an impact for the public, and that they're also actionable, that in fact individuals can take action.
One of our efforts within Oregon is to promote the use among physicians and insurance companies of evidence-based guidelines. The two that we favor in Oregon are the United States Preventative Task Force, which is USPSTF, and also the National Comprehensive Cancer Network, which we shorten to NCCN. And using those guidelines as we talk with physicians and as we talk with insurance companies, really help them get a sense of of best practices, and we incorporate that into the Tier 1 recommendations, which include such recommendations.
So, Bev, as a Department of Health, how do you parse out what is actionable and what is not?
We've had a robust family health history promotion effort for some years, so to have the information come out with the evidence-based recommendation was really a great importance, I think, to public health, is that 2 of these recommendations were included for the first time in Healthy People 2020 objectives, and that's really huge for public health.
It must be difficult with all the competing priorities you have in public health on a state level, and I'd love to hear each of you talk about how you make a decision to go forward with something like this.
I would like to try to convey that the Michigan Department of Community Health, and I would imagine it would be the same for the other 2 states, it's never a decision that's solely made by us, although we are a really good facilitator and neutral convener for bringing multiple parties together, but it's actually many forces coming together at the same time that made us believe that this was the right time to implement that.
To add to that, I can clearly remember back to the 90s when the BRCA gene was actually first discovered. And as we heard and read more about that in the news, and I had discussions with my colleague who's the newborn screening director, and we're like, yeah, we need to be doing something about this cancer gene in public health, and what is going to be the role of public health. They had formed an organization called the Michigan Cancer Consortium, which is an organization of organizations, and now I think there's 150 some organizations are members, and they very much facilitated the formation of an organization called the Michigan Cancer Genetics Alliance, because they wanted to have an organization that could be part of the Michigan Cancer Consortium, which would be the voice of genetics and genomics with respect to cancer.
Because of that Michigan Cancer Genetics Alliance, now we have people on the Michigan Cancer Consortium board that represent cancer genetics, and in 2009 they made the revolutionary decision to make it an entire goal with multiple strategies and activities related to cancer genomics. That is amazing to have over 100 partners across the state from all different realms all working towards your own goal.
Bev, how about you in Connecticut? What steps did you take to get to this decision?
We made a unique kind of outreach to our Connecticut Tumor Registry and our statewide group of tumor registrars that come together. And we had this great Healthy People 2020 action project. We had already been sharing with them what we would like to do, getting their input. And that really helped us because the one particular funding award we had was only 12 months. So having these partnerships already established was really critical. I think that the external and internal partnerships and having people invested in this effort is absolutely critical.
Summer, how about Oregon?
Well, similar to what Bev discussed, we started back in 2000 with family history and really just talking about the very useful tool that family history collection and analysis can be, and reaching out to a variety of groups within the public health division, just having them collect that information or consider collecting it. And from that, our partnerships expanded outside of the public health realm and into the clinician's office. And as we started to build our partnerships, we found certain champions, like Bev mentioned, and these champions who have a passion around particular diseases like heritable breast cancer are really crucial to the work that we do. They're the people who could help facilitate, but we can't do the work alone. And so having expanded partnerships and having really passionate advocates is a great help. Back then, we also started with surveillance activities, and this has been crucial for us. We have not only the clinical guidelines, but now we have some data in Oregon that says, there's a desperate need here. People are not being screened appropriately. And so we have the clinical recommendations, we have our surveillance data, and then when we tie in these Tier 1 genomic tests and ways of working with healthcare, it's just amazing what we can do to have all of that come together and just really underline the need and the action.
And to have that be the kind of the basis of the education outreach effort, I think
Absolutely.
is so critical.
Yeah, and it doesn't matter who we're talking to, whether it's a layperson or a clinician or the insurance companies, like everyone can gather around this when we can show the need and the action.
And I think it's interesting too, because I think when you embark on taking those pieces and having them be part of a larger education effort and increasing the awareness among a number of different players in the community, being providers or affected families or the public, doors start to open. I think the conversation really goes to a whole nother level, and more people coming to the table looking at, well, what should we be next? You know, what should we be doing next with this information? How can we more completely integrate this, you know, into our state?
And I definitely agree with everything that you've said there. And I love Bev's example about working with the cancer registrars, because that is existing data that every state should have. And so that is what is really amazing, when you can find something that's been existing there and look at it in a brand new way with a genomics lens. And it's really, you know, something that every state should think about doing.
It is a novel and new and novel approach, and we really noticed it because we did piggyback on what Michigan had accomplished in using the tumor registry data from each individual hospital. It really made them sit up and take notice and say, we are seeing patients that are affected by these syndromes, and here, this is your own data extrapolated in this form, and here are evidence-based recommendations that should apply to these individuals. These aren't numbers, these are people who have these conditions that you're seeing, that you're reporting on, and we're just giving this information back.
We really are concerned about what is going to be of most benefit, you know, for the public, for the public's health.
We have it all posted, it's online. Other states can look at this and not have to recreate the wheel, and really go back and look at how can we use what these states have developed as a foundation.
And so this was the very first time that the state was reaching out to the local cancer registry with information and giving them data in a new way, with educational materials and important policies related to the USPSTF guidelines or the EGAPP guidelines. In a 2-year period, Michigan, we had over 15,000 cases of the 64,000 that are reported each year that were identified at high risk and in need of cancer genetic services. And each one of those cases was included in a profile that went back to the local cancer registry and key administrators within that hospital system. And that's what we call the bi-directional reporting.
The next step is then, what does this data mean? What do they do with it? How does that open doors to access services, to try to enact these recommendations for for the patients and the people affected? One thing that we were able to do with our initiative is not only put out word and information about the evidence-based guidelines, but to offer a grand rounds training. 70% of the hospitals in Connecticut had received an on-site training about these evidence-based recommendations and how they should be used for patient care, delivered by a senior cancer genetic counselor. When we asked for a participant feedback survey, 90% of the folks said that they had an increased appreciation now for the use of family health history relating to these evidence-based guidelines, and a majority of them also said that they were planning to incorporate this information into their practice. So we were wildly ecstatic over, you know, the impact. So here again, data opened the doors. We were able to not just provide the information, to be able to process it with a cancer genetic counselor and give case examples about how you should go back and get this information to patients.
And in Oregon, we're actually looking at the Oregon Cancer Registry data and contacting any doctor who's been diagnosing breast cancer in a patient and sending them a letter about evidence-based guidelines, the risk factors that we want them to be aware of, and other information about how to contact local genetic counselors and such. And we're also sending their patients a similar letter if they are found to be at high risk and in need of genetic counseling.
And every state, too, is quite different about what's allowable within their state cancer registry. Some of it is actually dictated by law within the state. Some of it is dictated by the state cancer registrar's interpretation of that law.
I do want to mention that one of the Tier 1 recommendations around BRCA is not testing. It's about counseling. And that's really important for people to understand the difference, because what we are aiming for is to have more people at high risk receive counseling that will help them talk with their families about risk, will help them decide whether or not they want to have testing, because that's a personal choice. And we're not recommending testing, we're recommending a really informed decision about how you want to proceed.
So, Summer, you bring up a good point, because if we're increasing the desire for people to receive counseling, to make informed decisions, to even be found that they may in fact need testing, what do we do about the insurance issues?
That's a really important question, and every state right now has a different answer. Right now in Oregon, we've worked with our Medicaid program, and they actually cover genetic testing following the USPSTF and the NCCN guidelines since 2007. And we've noticed from our data that the number of people in the Medicaid population who are, and not just appropriate for testing, but receive the testing has been rising. And that's very encouraging. So our next step in Oregon is to talk with the Oregon insurers and share with them information about the cost benefits of counseling and working with the high-risk populations to identify what their exact risk is.
So what happened in 2008 when we started this work, we identified 4 health plans in Michigan, of those 24, that actually had exemplary policies for the BRCA embracing the 2005 recommendation. Now, in 2013, we've increased that number to 14. Those 10 health plans that have developed written policies cover over 6 million of our 10 million Michigan residents. So it's those kinds of numbers that you go, wow. We developed a policy that says that they have to follow 3 things. 1, they have to have a written policy for BRCA counseling and testing. 2, that policy must cover those that have a family history of breast and ovarian cancer. Many only cover those that have a personal history of breast and ovarian cancer, but it must cover those women that have a family history. And the 3rd thing was the most trickiest. We actually make sure that it either says that they either strongly recommend or require genetic counseling prior to testing. And we have found that it does also seem to be resulting in more appropriate testing, as well as definitely more cost savings for these health plans. And I'm not sure, but many people think it's one of many factors that have also led to much greater access to genetic services in Michigan. In 2008, we had 8 clinics in our state of Michigan that offered cancer genetic services by board-certified individuals in genetics. And now we've increased that to 16 clinics. And many of those clinics have just been added on in the last year or 2.
It sounds to me like all of these efforts so far have already produced, in your eyes, visible cost savings, both to individuals who, if you can be screened and do preventative things or find out about a cancer early, you save yourself certainly in terms of economic and life quality costs. And then it sounds like for the state as well, and probably for the insurers.
Yeah, we've identified a new need, actually, that's much related to this question that we call cascade screening. And with cascade screening, what you do is you actually identify an individual in a family that has a hereditary cancer syndrome or any other type of genetic condition that would be dominant. So with BRCA or Lynch syndrome, that all of your immediate biological relatives have a 1 in 2 chance of also having that hereditary cancer syndrome. And once you identify a specific genetic change in an individual, in a family, now you can actually look for that specific genetic change in all of those immediate family members. And so the testing, when you know the specific mutation, the cost goes down significantly. So not only is the cost much less, but also the effectiveness of that testing is incredible. But as far as a population health strategy goes, as far as information getting to payers and non-genetic providers, this is where our new strategy is going from 2013 to beyond.
And Deb, I think you're really hitting on one of the biggest roles for genomics in public health. It's about trying to identify the people who are at the highest risk. In public health, we think about all kinds of other risk factors for the population, whether it be, environmental exposures or behaviors. Genomics brings another dimension to help us identify very accurately, in most cases, who is at the highest risk, who needs the services the most, and gives us a way to really target those folks where the screening tests, whatever other interventions are available for that particular condition will make the most difference.
So if you were going to give advice to your sister and brother states, what one thing would you say?
Start with your partnerships. Look around within the public health division, who can you connect with, and then broaden it out. But while you're doing that, we found in Oregon that starting surveillance and just you can go from simple to complex, but one of the most simple things might be within your public health division, talking with your cancer registry, or seeing if the breast and cervical cancer program is tracking health history information, or the WISE woman, what sort of information within your realm in the public health services area is being collected already. And that is a really great start as you branch out into other partners and start looking around for further work, having that baseline of data, because you need to be able to measure things to know if you're fixing the problem.
I think one of the tips that I would like to give is that you need to be respectful of your chronic disease program partners. Everybody's very busy. So you have to be very creative in finding the small little ways that you can just sort of start to insert the genomics perspective, like Deb said, viewing things through the genomics lens. And then you need to be patient to some degree. I mean, we've been working on this in Michigan, since the late 90s. You're not going to see huge changes instantly overnight. But to me, there's no doubt that really every state needs to start trying to think about genomics, because it's here to stay.
I think the advice to states would be to start someplace, start a dialogue, and do what you can with what you have there. And if you start sharing information such as regarding the evidence-based recommendations, how this can accentuate their family health history message, which is a thread that goes across all areas of chronic disease, that's really critical. And the more I think that you work to inform folks, I think those doors open, and again, have this not be burdensome, but to accent what they're already doing.
I would tell states that are thinking about doing this, or clinical partners, or patient support group, to think about your state's comprehensive cancer state plan. Pull that out, because in 2010 we took a look at all 50 states. 2/3, or 32 specifically in 2010, had specific genomics goals, objectives, or strategies already within that state plan. That means that there's already been buy-in by all those partners, and something has already been identified. And if there's a long list of objectives or strategies, I would strongly recommend people think about the Healthy People 2020 objectives, and anything that's related to increasing the number of women with a family history of breast or ovarian cancer referred for genetic counseling. That's one objective. Or number 2 is the second objective, which we haven't talked about so much, which is increasing the proportion of newly diagnosed colorectal cancer patients screened for Lynch syndrome.
So states really shouldn't feel alone, it sounds like. They have you all as resources, having carved the path before them. Can you say a bit about EGAPP?
EGAPP is something that's ran out of CDC's Office of Public Health Genomics. It is an evidence-based review of genetic tests, very similar to what USPSTF goes through. And they try to think about a specific genetic application for a specific population, and is there sufficient evidence based on all 3 of those factors to say that this should be being used for population benefit. And EGAPP, that acronym, I know we're into acronyms today, stands for Evaluation of Genomic Applications in Practice and Prevention. And in 2009, EGAPP came out with the very first recommendation that said that there was sufficient evidence to recommend that all newly diagnosed colorectal cancer patients, all, regardless of age, family history, or previous personal history, should be screened for Lynch syndrome for the benefit of their unaffected family members. So this very much calls to that cascade screening approach that we're talking about. That EGAPP recommendation has had greater impact than most people would even realize. In 2008, there were about 1,200 colorectal cancer cases that were screened for Lynch syndrome under these guidelines. Our most recent data is showing now that it's over 12,000 cases.
What does the future hold? What are you thinking about?
Well, we're actually quite excited about one of the other Tier 1 applications that we haven't talked much about today so far, And that would have to do with familial hypercholesterolemia, which is a very common genetic condition. Some people say it's the most common, affecting about 1 out of 500 people, which leads to very high cholesterol levels and very early heart disease. That's detectable. And there are, strategies for reducing the risk of disease and adverse outcomes in people who have it. And recently there's actually been a recommendation that's come out from the American Academy of Pediatrics for universal cholesterol screening during childhood. This is a huge opportunity to start to really put into play that early identification and prevention strategy for all children and their families. And the cascade screening would be very relevant here if you identify a child who has very significantly high cholesterol levels at a young age, and then work backwards into the family who may or may not realize that they have a risk factor there.
So you've all expressed delight at various aspects of this program, and I can see that it's been a very, very powerful thing. And I think it'd be great if each of you could talk about one area that surprised you in as you went forward in this. So if you could describe one thing that surprised you in your efforts, what would it be? And Summer, let's start with you.
I met 3 different women that had been tested early on, just in 1996 when the BRCA test first came out. And they told me their family history story of mothers and aunts and uncles and a dad who suffered from breast or ovarian or the related cancers. And it was heartbreaking. But then the story changed with them. They were diagnosed with cancer. They got testing, and they shared that information with their family members. And so they had stories of children and grandchildren, and one woman even had great-grandchildren who were old enough to decide whether or not they wanted to be counseled, and some decided to get testing. Many did not carry any of the mutations in the family, and others did. And those who found out that they were a mutation carrier then had actionable things to do. And none of those family members, as we cascade down, have died of cancer.
I love this story, and why I love this story is because family history is a modifiable risk factor.
Yes.
That was something that we had seen in state plans, sometimes that it was put under a non-modifiable risk factor. But this is actually the best story to end on, I think, because family history for each one of those women is going to look a lot different in this generation and future generations.
Well, I want to thank you all. I think you've made it very clear how states could move forward with Tier 1 screening, how perhaps cascade screening is in all of our futures, one would hope, how you can do a lot with little resources, and how partnerships and collaborations seem to really save the day. So thank you all.
Thank you.